My brother, you give her a ticket, she got to go in. It was the and I was, that's what I was looking at. He didn't help me.
I'm going to bring my computer down someday.
They do all of like a lot of this in November. We'll have facial hair notices. So a lot of our in November, you're going to start to see a lot of men with facial hair. And some of our friends do it. Their wives are so upset about it. And the men just like, yes, it's a big thing. That's why I was like, anyway.
Ski season isn't too far away.
That was her answer.
I got to see some past this year. He's hurt.
So my wife, she got a
you know what? It's hurting. Should be good to go here.
Anyway.
Yeah, okay. I mean, I got a back. Company one.
Hey, Jared. What's your name?
stranger.
Oh, wait, were you here?
Yeah. I don't have to ask if you're enjoying retirement.
No, well, I've been gone this year. I was just telling Lana, I've been gone 8 trips since I retired.
Yeah.
And then now we got Husky football.
So now I can't go anywhere.
But I am kind of locked in, although I missed the BYU game because I had my brother-in-law's birthday party down in California.
I let Dennis know that he was
BYU game, that was the only game the Huskies played really well.
You should, yeah, you're lucky you missed the word.
Oh, I watched that. We only lost 2, but then we had a field goal.
I know. So I'm sorry. So only lost one.
That's the end of the season.
Well, that's a championship. But you know what? If they will take the road second, but they have to win out. I have to go. Sorry. Trust me with that? No, I don't.
Truth comes out.
No, I don't.
Hey, I do this for my kids all the time. No, I don't trust you. I'll just do it myself.
Well, actually, it's true. It is. My daughter's an engineer.
Oh my God.
No, but again, she doesn't even talk to me.
And it just doesn't make any sense.
I'll tell you mine. Russian
But you can't.
Right, I don't know. So anyway, more to come, but I just
Here's our problem.
I know.
My old nurse is, her son works for satellite intelligence for the Navy. So he's not a doctor of anything.
There you go.
So I said, so Austin, can you read my license plate for space? He goes, and I can tell you and he says, I can tell you exactly where you've been.
And what you've done wrong.
But I mean, they have stuff.
Oh, yeah.
His son-in-law's dad says, oh, we don't have to worry. I said, why is that? Because
Yeah, that's what I wanted.
you don't have to take it down. All you have to do is get a missile near him and it blows up all their electronics. So then they just fall in the water. So that's why nobody cares, is because they know they can already deal with it.
So it's a zero-sum game. They can do that to us as well.
I don't know that. I'm sure they're showing
Russians are
Yes, they've spent all this money making all these cities that nobody exists in, and they're actually in debt. And they don't have enough money to support them. So they're in their So they own like 2% of our state right now, like, and they own. But I'm sitting there like, you didn't think about it. I mean, like, because you think it's just, all right.
But they've done that. They've done it.
The thing is, it no longer is one country affecting themselves. It's like they go down, everybody
goes somewhere.
Yeah, but I'm all right. The whole country like changes. I'm scared. know they don't make wine, so you don't care, but
No, it is amazing. I've been to China, the airport is attacked by them. It's beautiful, but nobody's there.
when they have cities that nobody lives in, that they
Well, that's how they built their economy.
I know, yeah. That's all these Phantom projects. Yeah. They showed up.
Oh, it's incredible.
I know too bad, but
They have the Yangtze River.
the Three Gorges.
They raised it up several hundred feet, and they had to move all the people. And the other things, they built bridges across the Yangtze River. You can make like Golden Gate bridges, and about 15 or 20 of them in just a few years. They built it and moved just like these up. So they have the manpower, but it is amazing what they can do.
Well, I think the question is, they don't have the labor is still cheap. We had one of the comics on TV. He goes, "Well, yeah, we're going to switch. Apple's going to switch manufacturing to the United States. So here's your iMac with $12. Because it's $112."
That's what I'm saying. The 10,000.
But then they said that they've got all these secret, programs in our computers that they can monitor. And they've got chips in our computers. They're reading. Oh my gosh, man! How long ago was it?
Is that you guys doing it?
Yeah. I think if you just
Some places eat, right?
Yeah, well, that's what it's right now.
I think this is Steven.
I was going to say, Steve,
This might be Steve.
I've stopped
Steve Springmeyer. I'm trying to figure out.
Not mine.
just like
This is an old time picture.
Yeah.
Yeah. Mike, who's the third person? I don't know. I thought maybe you know him.
That's Springmeyer.
I don't remember. Steve would know. I've got another. I can send one to Steve. I was going through my stuff and I thought, that's a quaint old picture. That was when we used to go to the ITS meeting. Yeah. What a great dodge that was. You could put your hotel into your meeting
Were you still living?
and your lift ticket. So.
Were you still living in Utah?
No, I was here.
Utah.
My chief resident was a med student.
And Springmeyer was there too.
Yeah,
Springmeyer was in Utah.
Steve was born and raised in Utah. It's a great training program. When I went to the NIH, I thought I was going to go back there and get snowed until I realized that I had better training than anybody in the whole.
What a campus, that's beautiful.
What that is, Utah? Yeah, well, I went there once since I left.
One time?
Only one time. Well, I only skied there once, but I also drove up to the university. You're right, it's totally changed. And I started to walk through the buildings. There was security and stuff like that. And it's a little bit it's like going to children's hospital. Children go through so much security. It's crazy. Anyhow.
Well,
Yeah, I know.
but if you had a kid there, you'd love the security. You'd try to do a little bit of business there. The major reason for admit to children's is still asthma exacerbations. Right. Yeah. The major reason you can't get in. You can't talk to anybody.
I might have King Panther boots and like pre-M5.
I
Now this is old.
But just I said the style of the clothes could have gone back to closer to the 70s, early 80s.
Early 80s.
Yeah.
What are you talking about? It still works.
The one
Yeah, but you've never left the early 80s, Jerry. That's different.
Is that the difference?
That's the difference. Boy, Drew's looking tired.
He's working hard.
He's working hard.
He's working everywhere.
He says they schedule him for 6 new patients in an hour. I said, that's a brilliant schedule.
6 and 9.
I said, how do you do that? Just introduce yourself and say, come back in 6 weeks, I'll see you.
Well, it's hopefully it's got fellowships. Residents. Most of them.
No, I mean,
That's true.
One fellow.
only one fellow. Everybody's pointing at you. Are you seeing all 6 of Drew's patients in an hour?
That's right. 6 patients in an hour?
Why not?
Look at that smile. No.
No.
How's the knee coming?
Oh, I'm going to be skiing. I'm just hoping I'm not wearing a brace. I got it fixed in April. But I'm healing at glacial speed is what my doctor told me.
What did they do to you?
I had to reattach my quad tendon. So they drilled holes in my patella, and he says, I got this gnarly strong scissors that you can't break. And he shows it to me, it looks like my weed whacker. And I can't feel them because there are big knots in it.
I mean, I just think it's just so hard to just being like.
Anyway, it's funny how fast your muscles atrophy though when you don't have
Oh, yeah, absolutely. And Dr. Braun, yeah. Stay up. I'm gonna get my ankle redone in December. Oh, really? Are you guys going to go on it now? Hopefully,
I don't think they're gonna let another Larry cross the
I'm telling you, be ready to
No, it's in real as well, and I think
negotiate.
I'm just telling you.
You take like a bunion surgery. It takes forever to come back. When you have that done, and it was months.
Bunion is major. It's like, what is this here? No, the cup. You see, rotator cuff?
Rotator cuff.
Yeah, it takes like a year.
Well, I know what that, it took a good 6 months to get down to like barely cut.
That's
The
what
first spring, yeah.
But she still has just about ready. And she's got degree infections. It's like, so he said put her on a biologic. So that's great. Which one do you want to know?
What you been doing other than getting ready for surgery?
Back from Seattle, Vancouver, and party.
Okay, sounds great.
Yeah, well, I have a nice lady, 60 years old.
It's gonna be like
Sinus disease. And she's like one of my
And then by the time I think it's
I'm sure you've never seen any of that. Yeah. This is where Miss Gail, I got a guy yesterday. So I was just shocked. Just like, how do you feel?
Played one game.
Right, and I don't want to burden you with I'm trying to cherry pick the ones that I don't know what to do.
The only trouble is now we gotta play them over there. It used to be open. It looks like there's a pretty good chance we're running out of probably. Or we can bring chairs.
And I saw what name she
All
was.
those fans can change everything.
Was that anybody?
Oh, really?
We didn't hear that well. Oh, I'm sorry. I did. That's right. Okay, that's what I thought. I just I'm sorry. Right.
Let's everybody take a seat and get started. For Bill, our chief, to come in and take a seat and bring a couple more chairs in. Normally this door behind you is open and we have a double-sized room, but I don't know, there's some kind of regulations here. We're not supposed to fiddle with that door. It's open, it stays open. It's closed, it's not supposed to open. Anyway, I want to thank Andrew Blauvelt for coming up here from Oregon and to give us a talk, as you can see as well as I, update on the pathogenesis and treatment of atopic dermatitis. And really a story, again, more and more of our presentation have to do with biologics and continuing release of biologics, success in biologics in treatment of both dermatology and allergic diseases. Actually, just 2 days ago, or maybe now 3 days ago, one of the main ones he's going to talk about is not only approved for atopic dermatitis, but now approved for asthma as well. So truly a conjoint interest between our two disciplines. So it's all yours.
All right, thank you, Len. So I'm going to tell you a little bit about my background. So I appreciate the invitation. I'm glad to be here. I'm happy to be here. I've heard a lot about this conference, the history of this conference. So I'm a dermatologist and an immunologist. After my clinical training, I went to the NIH and did a 4-year immunology fellowship, basic science fellowship. I stayed on at the NIH for another 8 years and ran my own laboratory. So I was there for 12 years, from 92 to 2004. Mostly worked on viruses. I worked on HIV and Kapsi's herpes virus. It was a fun, wonderful place. I know some of you have been to NIH and have trained there. I've worked in Building 10, kind of the main building there. Then I was brought west. I went to Portland in 2004. Became professor of dermatology and microbiology at OHSU. Kind of switched my research interest, started working in the immunology of psoriasis, which was a hot topic at the time because we were learning about a new pathway in psoriasis called IL-23 Th17 pathway. Started working on that. Spent 7 years at OHSU, and then moved from the university 7 years ago. I closed my laboratory and bought a business. I bought Oregon Medical Research Center, which is a private clinical study center. So it's a standalone, not university-based, private study center doing exclusively studies in dermatology pipeline drugs. So for the last 7 years, I tell people, I miss academics, but it's been a really fun job because I gotten to play with an incredible array of drugs that are in our specialty and probably in your specialty as well, and 21st century medicine. It's been a fun job. Today I'm going to kind of tell you the pipeline of AD and kind of the background of it and why it's exciting and of course relevant for you. So that's my background, kind of what I've been doing, and of course, because now my job is to work with industry, this is quite a long list. So I do consulting as well for the companies, given my academic background, the immunology background. So I work on protocol development for these companies, I work on data analysis, and I'm ending up on a lot of the papers for the pipeline drug as well because of my background. I do promotional speaking for just 2 companies, Regeneron Sanofi, the makers of Dupixent, and Janssen, that's the makers of a biologic for psoriasis. So I don't do a lot of promotional speaking. I like to do these kinds of talks because these are all my own slides. This is my my story in my words. So just a little bit of background on AD. I know you guys know AD, but just to know that it's a common disease. It's also moderate to severe disease, which we're going to be focusing on today, is also quite common. So these would be potential patients for systemic therapy, or the patients with more moderate to severe disease. So I like to see it as when I see a patient with eczema, basically I'm looking at them and just trying to decide whether this is a candidate for topical therapy or a candidate for systemic therapy. So I don't use mild, moderate, severe. I'm looking at this patient, talking to them, looking objectively at their skin disease, asking them about their prior history of topical therapy, how much it's impacting their lives. And if they failed a lot of topical therapy and it's really impacting their lives, then they're going to be in the systemic therapy bucket. And if it's relatively mild and we have an optimized topical therapy, then I'm going to be treating that patient as a topical therapy candidate. So kind of those are I kind of dichotomize, if you will, when I'm seeing a patient. Most of the time that's pretty easy. Sometimes, patients in between, we might try optimizing topical therapy first, but then I'll move to systemic therapy. We know that AD is I actually believe it's a horrible disease. I've worked a lot in psoriasis, which my father had severe psoriasis, terrible quality of life. It's been documented through the years. But then when you look at the quality of life scores in moderate to severe AD, they're actually higher than, they're worse than what you see in moderate to severe psoriasis. And it's dominated by the itch. So the itch preoccupies these folks completely. It interferes with their social activities, their sleeping, their work activities, pretty much dominates their life. So especially patients with more severe disease are going to be dominated by itch. And when these drugs that are in trials for AD, itch is the dominant patient-reported outcome that we're looking at. So we're measuring, asking patients about their itch and control of their itch in these trials of these new drugs. We're also asking about sleep. And sleep is probably the second most dominant sort of patient-reported outcome. And so itch and sleep, they often are going together. Patients do not sleep well when they have more severe AD, bottom line. Just some data on sleep impairment, kind of already went over this. And basically we do see higher incidences of a variety of psychological problems, anxiety, depression, attention deficit disorder, sexual dysfunction, decreased work productivity. So all of these have been documented, well documented in the moderate to severe AD population. Again, kind of highlighting the impact on the quality of life of these folks. So you know this slide better than me. AD is not a standalone disease. We have common comorbidities, atopic dermatitis, as you see here. So the patients commonly have other atopic disorders. What you might not know in some newer data is that this seems to be a common theme that's evolving with chronic inflammatory diseases in general. Psoriasis is a chronic inflammatory disease. Rheumatoid arthritis is also, what we're seeing is that these diseases are tending to coexist, and patients actually have increased risk of rheumatoid arthritis, Crohn's disease, atherosclerosis, heart attack, and stroke. AD patients, so this is more evolving data, looking at large epidemiological databases showing these associations. Again, but it's consistent with kind of what we're seeing with, for example, RA studies. They have a higher incidence of heart disease as well. Psoriasis is linked with heart disease as well. So this common theme that's evolving here is chronic inflammation. Chronic inflammatory diseases being linked to inflammation elsewhere in the body. This kind of goes back to sort of the idea of topical versus systemic. If you look at the number of episodes and kind of divide AD by moderate versus severe, You see patients who are clearly need systemic therapy. That would be those in the systemic or severe category, and those that are probably need systemic therapy in the moderate category, because the frequency of episodes and the frequency of symptoms and sleep disturbance are quite marked over the course of the year. So it kind of takes me to the bulk of the talk. So we're going to be talking now the rest of the time about therapy and how it kind of links to the pathogenesis of the disease and what we've been learning. So the common theme here, and you know this as well as me, the more and more we learn about the pathogenesis of the disease, the better we can identify targets. And the better the target is, the better we can get a medicine. And we're in this era now where monoclonal antibodies can be developed against any target. So the technology is very fluent. It's relatively easy now to create a monoclonal antibody to a target, but we need the basic science. We need to understand the tissue, the disease, to come up with the ideal targets. And I would posit for you all that the ideal target for any disease is an Achilles heel protein. So where the protein, let's say, is absolutely required for the disease, yet is not essential to life or essential to normal functioning. So that's the key sort of principle behind monoclonal antibody therapy for all diseases, is try to identify that Achilles heel for that pathogenic process, yet not critical to sort of a normal function or normal immune control. And we're getting better and better and better at this as far as, because the science is evolving, and not just AD, but in a variety of diseases. Cancer is a great example where the targets are becoming more and more specific to cancer and less specific to the overall immune system. And then we make a monoclonal antibody to that particular protein. That's an Achilles heel protein, I call it, for cancer. And then we have a very much more targeted therapy than we had, for instance, 10 years ago. So if we look at AD, it's kind of interesting. It is it's a simple slide. I like to use it still. I've had this slide forever. It's not just an immunologic disease. We know that there is a prominent genetic component of atopic dermatitis. So atopy runs in families. We see, asthma, hay fever, AD in family members. We have a number of genetic associations with AD. But we also know that the environment is very prominent in the pathogenesis of this disease. Patients report food allergies, environmental, airborne allergens, allergens to pets, soaps, detergents. And basically, I like to summarize AD as sensitive skin. So it's when patients come in, a lot of times they'll say to me, if I can just find the food to avoid, if I can just find that one thing, I'm working at it. I'm working on. I avoided this, and this, and I hate to break the news to them, but I try to say to the patients that I think it's kind of fruitless to try to find a single factor, because the answer often in these patients is all of the above. They are reactive. They're reactive to a wide variety of things. And to identify a single thing, it's helpful if they know that dogs make their skin worse, then don't have a dog. That's going to be helpful, right? But we're not looking at a cure by avoiding certain things. So to me, their skin, my patients, they can react to anything. Changes in the weather, dry weather, emotional stress, fats, certain foods, and so forth. So we have this complex mixture. The interesting thing to me is that the targeted therapies that I'm going to be talking about today are all addressing the immune system piece, the inflammation piece. They're really not addressing the genetic defects we see, for instance, FILLAGRIN defects, and they're not really addressing in the environment. So these trials are going on without any particular advice or focus on potential allergens. So we're letting the patients kind of, be exposed to whatever there's no advice in these trials. In an AD trial, we collect information on potential allergens, but then we just give the drug. So we're really not changing the top piece at all. And I like to say that also we have terrific drugs now and terrific ones coming, but we're not changing the underlying basis of the disease. So they're still going to have the genetic defects, and they're still going to have the environmental exposures. So it's not a cure in any way, but it's hitting a key piece, sort of the inflammation part of the disease that we've been focused on recently. So you probably are used to a lot of complex pathogenesis slides for a variety of diseases. You've seen this type of slide before. I like to just kind of summarize and sum up and say the main activities in the center there that I've circled.
I think there's a pointer.
Okay.
Is there a mouse up there?
Yeah. Oops. Just changed my. Anyways, the red circle. So the red circle here is where the focus has been, and that's on the Th2 cytokines. In particular, IL-4 and IL-13 appear to play a central role in AD pathogenesis. Now, doesn't mean they're the only players and the only targets. There are actually some cytokines that are upstream of IL-4 and IL-13, in particular IL-33, which you see to the right there. There are monoclonal antibodies targeting IL-33, which drives IL-4 and IL-13 production, so what I say more upstream in this cascade. So those drugs are in early phase development, but we're kind of in this more midstream. We do know about what IL-4 and IL-13 do to the skin, so I'm going to show you some background. But kind of the main targets that we're looking at these days, IL-4, IL-13, IL-5, which is also a Th2 cytokine. It's more involved in eosinophil function. IL-31 is a cytokine that's called the itch cytokine. It's basically shown to mediate acute itch. And so they're actually targeting therapies to IL-31 that we may see on the market someday. IL-33 and TSLP, I would put those more in the upstream category of IL-4 and IL-13. So there's investigations into targeting those cytokines as well. But you can kind of see it's centered around these Th2 cytokines. They're involved in a number of allergy-mediated diseases. So not just atopic dermatitis, but asthma, hay fever, eosinophilic esophagitis, nasal polyposis. So for all those types of diseases, we see Th2 cytokines being dominant in the pathogenesis, which kind of opens up a lot of these therapies, not just for atopic dermatitis, but for asthma as well and other allergic-mediated diseases. We know that Th2 cytokines decrease FILLAGRIN production and antimicrobial peptide production in the skin. Why is that important? Because FILLAGRIN is a main epidermal barrier function protein. And so we see genetic defects in FILLAGRIN associated with atopic dermatitis. And then on top of that, we see that Th2 cytokines can decrease FILLAGRIN production and impair the barrier of the skin. So it's a secondary effect. We know that the skin is more susceptible to infection. If a patient has eczema, it's susceptible to staph infection, herpes simplex infection, and a lot of people postulate it's due to the antimicrobial peptide decrease, so there are natural antibiotics in the skin being impaired in AD. So taking this a little further, I'm actually going to talk a little bit more about IL-13, because I think that IL-13 is there's more evidence from the laboratory that IL-13 is critical in pathogenesis. So it's interesting that IL-4 and IL-13, they both bind a receptor chain called IL-4R alpha, shown in the green there. And so one of the drugs I'm going to be talking about is Dupilumab or Dupixent. And that drug actually blocks IL-4R alpha. And by blocking IL-4R alpha in green, it blocks signaling of IL-4 and IL-13. So it's a single monoclonal antibody with one target, IL-4R alpha, but it's blocking function of two cytokines because it's blocking the docking site for both of those cytokines. So it's sitting on the cell surface, on the receptor, and now the cytokines, those two cytokines can't block and sit down. Recently, this paper showed that actually signaling through IL-4R alpha and JAK1 is the pathway involved in chronic itch. So if you ask whether Dupilumab affects itch or how it may affect itch, it's likely blocking chronic itch by blocking that signaling pathway. And interesting that IL-31, which I mentioned a few minutes ago, is more involved in acute itch. So if you're targeting there, you'd be expected to have a patient have less acute itch, but possibly more chronic itch. So it's kind of an interesting area right now. What itch receptors may be more important for AD, for example.
What's the difference between acute and chronic itch?
So time. I mean, when you look at, so these are mouse models. This was done in mouse models. But basically, an application of cutaneous sensitizers that mediate itch quickly versus mouse models that are more
So it's like time of onset of the
over
itch?
time, and the receptors that are activated go through a different pathway.
I'm just like saying, is like the time of onset of the itching, or is the how long the patient will have the itch?
So I think this work was done in mouse models, but in translating it into patients, I think patients, for example, with eczema are probably likely to have both components.
Yeah.
Both acute itch due to flares with allergens and chronic itch over time, just continually without the absence of. So in AD, likely both pathways are active.
So does this mean these receptors are on sensory nerves?
Yes.
We usually think of them as being on inflammatory
Right, they're on sensory nerves. That's what this is meant to be a nerve.
This black line.
Yes. I'm sorry. Yeah.
Does IL-4 and IL-13 signaling upregulate IL-31 production?
I'm not sure about
Curious
that.
if it's not.
I don't know.
I think veterinarians already have anti-IL-31
They do.
drugs.
They
Yeah.
do.
They, they work very well, don't they? And,
Yeah, I'm going to show one slide on nemolizumab. Nemo, we call it for short. It's an IL-31 receptor blocker, and it's been studied in a phase 2 study and published in New England Journal of Medicine in atopic dermatitis. So there is some data on blockade of IL-31 in atopic dermatitis, but it's just starting the phase 3 program. That's the farthest we have in humans with IL-31 blockade. I did mention genetic polymorphisms associated with AD, and it's interesting that there are IL-13 gene changes that are associated with AD, as shown here. So it's a gain of function, meaning that patients that have these polymorphisms have higher levels of IL-13 or more activity of IL-13. Now, if we look in skin, we have psoriasis as a control, another chronic inflammatory skin disease, and normal skin. We see higher levels of IL-13 on the left, and then we have the gene microarray analysis, and what we see in the panel of genes that are upregulated in AD is a pattern of IL-13 gene expression and IL-13 related genes. So sort of naively, patients may come in and say, well, I have skin disease, can I get this drug? It's these days, Dupilumab is not going to work in psoriasis, and the best psoriasis medicines are not going to do anything in AD. So inflammatory skin disease, yes, but that's about where the similarities stop. We're getting in distinctive, unique pathways for these two particular skin diseases.
In the group that have the IL-13 polymorphism, is there a subgroup that have particular overexpression of IL-13 and also have severe asthma? Is there?
I don't know the asthma data. I'm not sure. So in this particular paper, it's looking at the number of cells, actually so I just showed you RNA data. This is actually protein data, so they're doing staining within tissue for IL-13 positive cells, and basically you can see IL-4 and IL-13 positive cells both in mild lesions and subacute lesions and lichenified lesions. So basically you see these cytokines within all types of skin lesions by protein levels, positive cells. This is interesting to me because here we have circulating IL-13 positive cells, the likely Th2 T cells circulating AD, and it's correlative with the severity of AD. So we have mild, moderate, severe patients, and we see more and more CD4 positive, IL-13 positive cells in the circulation when we see more severe skin disease. And on the right, we have something called the SCORAD, which is a clinical scoring system used in Europe. We had a discussion last night. I guess you guys have tried to do some SCORADing in your department. I don't like it. It's very complicated. I don't recommend doing SCORAD. But anyway, it's a clinical severity measure seen in clinical trials. And here also you see a correlation with worsening skin scores and circulating IL-4 positive. IL-13 positive, CD4 positive cells. I alluded to this earlier, where we can do in vitro studies on keratinocytes by looking at INVOLUCRIN and FILLAGRIN expression by the epithelial cells. And here we're showing that with IL-13 addition, you see decreased production of INVOLUCRIN and FILLAGRIN. So I didn't mention, but INVOLUCRIN is another one of these mortar proteins, so bricks and mortar of the epidermis. Both of these proteins, INVOLUCRIN and FILLAGRIN, are involved in sort of sealing the epithelial barrier, providing a good barrier integrity. So you not only have genetic defects in these mortar type proteins that are in between keratinocytes, but you also have IL-4 and IL-13 decreasing the production of those proteins and further leading to impaired barrier. So I didn't really specifically mention it, but dermatologists think of the impaired barrier of AD as doing two things of consequence. One is allowing more water loss. So it's been shown that transepidermal barrier water loss is increased when the epithelial barrier is impaired. So if they don't have the sealant, if you will, more water is going to be evaporated. You're going to see more dry skin. The more the dry skin is around in AD patients, the more likely it's able to become inflamed. So as sort of a prophylactic measure for most of my patients, I recommend moisturization after bathing, usually within 5 minutes, to help try to exogenously provide a sealant or a barrier when the water starts to evaporate. The second thing that we think of is allowing more allergens to go through from the top. So more water coming out and more allergens or sensitizers coming in because of the impaired epithelial barrier. Okay. So I already showed a little bit of this but we're going to be talking about it in a little bit more detail. So this is the signaling of IL-4 and IL-13. IL-4 can signal through different pairs of receptors. So on the left-hand side, the most important thing I want you to see is the blue chain. The blue receptor chain is IL-4R-alpha, again, the target of dupilumab. So IL-4 can use IL-4R-alpha with a second chain called the common gamma receptor, or IL-13R-alpha. You don't really have to memorize this. You just have to know that 4 and 13 can both use the blue chain. Okay, they both use the IL-4R-alpha to signal. So the drugs that I'm going to be talking about are, one is Dupilumab, as shown here, targeting the red chain. And the other two that I'm going to mention briefly that are farther behind in development are Tralokinumab and Lebrikizumab, which selectively block IL-13. Because I think most researchers now think that IL-13 is the more dominant, more important cytokine for atopic dermatitis. Maybe different for asthma, but for atopic dermatitis, the bulk of the basic sign, and they're very closely related cytokines. So it's not that they're wildly different. So they're closely related, but most of the basic science work has been focused on IL-13. Thus, we have selective IL-13 blockers in development. So I'm going to go into some clinical studies data. So IgA is not immunoglobulin A. In this case, it stands for Investigators Global Assessment. It's a pretty easy score, and I recommend you guys actually use it in your practice because it's intuitive, it's simple, it's a scale from 0 to 4, 5-point scale. 0 means no eczema, clear. 1, IgA at 1 is almost clear. It's a minimal disease. 2 is mild, 3 is moderate, and 4 is severe. So to get into these systemic trials that I'm going to be mentioning, patients had to have an IgA of 3 or 4. So a global score of 3 or 4. So very simple, and I recommend it to practice because body surface area to me is really difficult to assess. In an eczema patient, it's kind of hard to tell where lesions stop and start. You come up with a good, accurate BSA. To me, it's just difficult. It takes more time. This is a basic thing. So if a patient's having a 3 or a 4, you should be thinking more along the lines of systemic therapy. EASI, which I'll be talking about as well, and showing data here, is a more complex score. It involves grading erythema, infiltration, excoriations, and lichenification. So 4 features of AD and in 4 body areas. So we're actually doing 16 measurements. So we score erythema in the head and neck, we score erythema in the lower extremities and so forth, and lichenification in each of the 4 areas. And then there's a math formula, and we come up with a number. And in the trials, you have to have 16 or higher on this score to be in the trial. So that's bad disease, by the way. So here's an example of my scoring for a patient that was in one of our trials. So this patient gets a 3 out of 3 for erythema, 2 out of 3 for induration or papulation. Not much lichenification here, maybe a little bit in the upper back, so 1 out of 3 for lichenifications, and a 3 out of 3 for excoriations. So this is kind of how you come up with an EASI score. So I'm going to just dive right into Dupilumab data because we have the most data on this particular drug. This was the major phase 3 paper. It involved 2 studies, Solo 1 and Solo 2. Patients, as I mentioned, had to have 3 or 4 global. They had to have an EASI of 16 or higher. They were called Solo because the patients were not allowed any other therapies. They were only told to moisturize. So moisturization and placebo shots versus moisturization and Dupilumab shots. Okay? There were 2 dosing regimens tested, every week shots versus every 2-week shots. So shown in blue versus green. And if we look on the left-hand side and we look at IgA, what this is measuring is the percentage of patients who are getting to 0 or 1. So they're getting an IgA score of clear or almost clear in 16 weeks. So they had to start at 3 to 4. And how many people get clear or get to minimal? We know now that this IgA 0-1 measurement is actually a very high bar that the FDA has established for success. So you see the result is about 40% of patients, what I call our great responders with this very high level response. What I'm going to show you on the right is a little less stringent bar for success. It's called the EASI 75, which means the percentage of patients who have a 75% or more improvement in their EASI score. So now we see about half of patients who are 75% or more improved by sort of a less stringent measure. I'm going to talk about another study where I was the first author. Basically, this was a 52-week study, so there were 3 phase 3 studies, major phase 3 studies, again, every week versus every 2 weeks. But this study allowed topical steroids. So all the patients were being treated with triamcinolone, basically mid-potency topical steroid plus Dupilumab, versus triamcinolone versus placebo shots. And it went over 52 weeks instead of 16 weeks. Okay? And I didn't emphasize this with the solo study, but I want to emphasize it here, is that if you look at the red box, the body surface area involved at the beginning of the study, the baseline characteristics was very, very high. So the average body surface area involvement was over 50% in this population. So I call it a tough crowd. These folks had widespread disease, or a miserable disease. About half of them had IgAs of 4, and about half had IgAs of 3. And then when we measured itch, they were anywhere from 7 to 8 out of 10 on an itch scale. So if you ask a patient, the worst imaginable itch is a 10, and no itch is a 0. They average between 7 and 8 going into the trial prior to receiving therapy. So the bottom line that I want you to learn from this is that these were really bad patients. They really came out of the woodwork because we didn't have any drug like this prior. So this was an easy study to enroll in because these patients were miserable. They had average disease duration, I don't know if it's up there, for 28 years. A lot of them had comorbid asthma, allergies, so forth, as you would expect. Okay, yeah, there's my highlighting of the comorbid diseases. All right, so this trial, again, it's different because there's topical steroids on board. So you see the placebo response in blue is 20% or so. So this is topical steroids alone, but again, in a population that really should be treated with systemic therapy, so you can only really get maybe a quarter at the most success rate with topical steroids in this population. But if you have Dupilumab, what you see is a big drop in the EASI scores, and what you see is the drop occurring predominantly in the first month. This is a rapid onset drug. You see improvement very quickly, and then you see sustainability here. The other important point is that the curves over time, over 52 weeks, actually show great durability. You don't see this drop-off in effect, at least over the course of a year. This is a mean improvement in the itch. So we see that over patients have about a 50% drop in their itch score. So if they started at 7, On average, they're going down to a 3.5 or so forth. So you see, you don't see a complete abolishment of itch, but a marked decrease in the itch scores, and sustained and occurring in the first month. So this is not my slide. This is from Eric Simpson, a colleague of mine at OHSU. Obviously, when you see before and afters, often we show some of our best pictures. So this would be a super responder, a patient who got to an IGA of 0 and started at a 4. So this patient went from a 4 to a 0. Again, I would say about a third to 40% of patients are going to have this really terrific response like this. The title of this slide says it all. All types of patients on Dupilumab do well, so there were subset analyses done on different types of patients, old versus young, men versus women, different BMI patients, with asthma, without asthma, allergic rhinitis, so forth, food allergies. What we see is all of the lines are shifted to the right, which means they all did well, and they're lining up very well with one another. So basically the bottom line here is what I have in the title, that young patients do just as well as old patients. Thin versus heavy, which is kind of interesting, because we often will see decreases in biologic responses in heavier patients, but we didn't really see that in this particular study. So I get this question a lot. I didn't show it. I showed you a third to 40% of patients doing terrific. What about the other patients, right? Out of 100 patients, how many do well, quote unquote? How many are happy? So here, this is a harder question to answer, because the company was told by the FDA, you have to use these endpoints as the primary endpoints. As I told you, the primary endpoints are pretty high bar. So it doesn't mean the other patients are not doing well or not happy. So I think you're going to be seeing in the literature a number of what we call secondary analyses being done on the whole population. And I'm just going to give you a hint of this. This was done as a poster this summer, where each dot here in green is a patient, and on the left hand, on the y-axis is the absolute EASI score. So if you go over to the left-hand side, basically what you see are single patients represented by a dot, and you see that all the EASI is above 16 at week 0. And then what you see over time is that the cloud, the dots kind of all go down. If you focus on the lower right, let's see if I can get right here. Actually, it's not showing up there. What you see over here at week 52 is actually most of the dots are low, right? But you have some patients. You have a few patients that are not doing well. But the bulk of the cloud is coming down. So the bulk of the patients are coming down. They're not all meeting the strict criteria for success, but you see most of them coming down and doing well. And you see an 85% drop. 85% drop in the average EASI score. Now we're talking. I think that makes it sound much more impressive than what I just showed you a few seconds ago about IGA 01, about 40%. You can tell patients they'll have about an 80 to 85% drop in their eczema score with this drug over time. So it's not 100% of patients. It's not 100% of patients getting clear, but I think most patients do well. I've treated over 100 patients now with this drug, both in my practice and in the study program, and this is my experience as well. I'd see that most patients, probably in my experience, from me, only I would say over 90% of my patients like this drug, have a great impact on their lives. And that's very different than saying it's only a 40% responding drug, right? So you got to be careful about, I think, kind of understanding and knowing about these endpoints that the FDA has selected. This IGA 01 in particular, I think it requires some education on knowing what that means to patients. All right, so I get asked, what about the patients who are not responding, or how do we evaluate them? So I'm aware of a few cases of patients who end up having cutaneous T-cell lymphoma. And I actually recommend that if you're treating a patient and nothing's happening to the skin, after a couple months, reconsider your diagnosis. I actually think that's worth, I told Len last night, I think that's worth a dermatology consult to actually consider several things. So a biopsy would tell you whether you're dealing with atopic dermatitis or cutaneous T-cell lymphoma, which can mimic that, so you can see T-cell lymphoma on biopsy. Another thing that's been highlighted recently in the literature is contact dermatitis, allergic contact dermatitis. So to contact allergens, and in particular on the face, in patients on Dupilumab, yet with prominent facial rashes. And so this is, I think, also an important thing to consider. If you have a patient who is not doing well, consider, so dermatologists would do patch testing to try to identify contact allergens to make this diagnosis. So another thing that your dermatology consultation could do is both biopsy and patch testing if you have a patient who's clearly not doing well with Dupilumab. The skin seems refractory or resistant. Rethink the diagnosis. Really, I think it means that you may not be dealing with eczema on the skin. All right, so now I'm going to show you some unpublished data, but that has been presented publicly. And this was an exciting study because the drug has now gone into children. So it's FDA approved for adults with AD, but we've now done studies in teenagers, and the results were revealed last month at a dermatology meeting in Paris. Very standard design, placebo versus every 4-week Dupilumab versus every 2-week, and this is a study done in 12 to 17-year-olds. I participated in this study as well. I'm a co-author on the paper. I have about 15 teenagers in this trial. They've, in my view, done very well, but I'll show you some data. This is interesting because at first blush, again, it looks like it doesn't work that well, because on the left-hand side, we have IGA 01 numbers. On the right-hand side, EASI 75. What we see here also is a very low placebo response rate. And if we subtract out the placebo response rate from the drug rate, it actually shows a little bit better response than we see in adults. So if adults, I don't know if you noticed, but the placebo response rate was in the 10 to 12% range, and we don't see that in the kids. It's a very low placebo response rate. So what you see is the drug effect being just as good in kids. Here's a less rigorous EASI 50 is a less rigorous standard, and you see nice drops, and over 50% of patients are achieving EASI 50 in this trial. All right, I'm going to tell you about another study that was recently published. This was an interesting study because most biologics are not tested in the context of immunization, right? So when they're on the market, we often get this label like no live immunizations, no live vaccines, because it wasn't tested. And so Regeneron Sanofi actually, we did a study where patients were on placebo or on Dupilumab for 12 weeks. And after 12 weeks of therapy, they were immunized, all the patients were immunized with tetanus and with meningococcus. So both of those are dead vaccines, but the purpose of this study was to determine whether the immune response to vaccination while on dupilumab was normal or not. And so what we saw at week 16 is that the immune response to tetanus on the upper left and the immune response to meningococcal vaccination was normal. Even the patients on dupilumab had a normal antibody response to vaccination 4 weeks earlier. On the lower panel, I'm showing IgE levels. So we know that IgE levels are often elevated in AD patients. And what we see, just as an aside, I haven't mentioned this yet, but total IgE levels come down with dupilumab, as you can see in the lower right-hand corner. Again, kind of what you would expect from a drug that's targeting Th2-mediated inflammation. I think this is an important study because we don't have a lot of studies like this. It always comes up in clinic, can I do immunizations? What's the effect of the biologic on immunization? We still need live vaccination studies done with these drugs, but nevertheless, I think this is an important one to know about. And then for you guys, look at the date. Oops, I forgot. I just made that label this morning, so I forgot the end parentheses. Little typo there. So on Saturday, I get a call, and I'm actually out hiking, and it's my Regeneron colleague who's all excited to tell me that it just got approved for asthma. So 3 days ago. So it actually is approved for 2 types of asthma: eosinophilic asthma, and asthma that is corticosteroid-dependent asthma as an add-on to steroids. And there were 2 independent studies published in the New England Journal of Medicine this past summer. I'm not going to go into the data. You guys know this data better than me. I encourage you to look at those 2 papers because now you have a new drug for patients who have difficult to control asthma. Not unexpected, right? A Th2 disease. We're targeting Th2 cytokines, so this is not an unexpected result. So I'm going to share a little bit of data from the AD trials. So in the AD trials, we did the Asthma Control Questionnaire, or ACQ-5. And of course, some patients had asthma, as I mentioned earlier. And the question is, did the asthma improve in the AD patients? And so this is rough data. It's questionnaire data. It's not objective data. It's subjective data. But you can see in patients that have ACQ score of greater than 1, which means less controlled asthma, you see a nice improvement in the symptomology of the asthma patients. So again, kind of this is not surprising, but this is some data that we've had for a while in the eczema population, what happens to the asthma. All right, I'm going to talk about safety now. I like this slide because it's only from one study. It's from the Lancet paper, the 52-week study. But it's a bottom line. I have the bottom line here in green and red. And the 2 major side effects that we've seen with this drug are injection site reactions, which we often will see with biologic therapy, and conjunctivitis. And I'm going to talk more about conjunctivitis in a minute. But basically, these are the 2 things that we've seen. In green, we actually saw less flares of atopic dermatitis, of course, and less skin infections. Less skin infections with dupilumab. And some people think, well, that's counterintuitive because you're treating a biologic, and a biologic is hitting the immune system, right? Well, it's not. It's actually, I think, intuitive because what are you doing when you're treating eczema? You're increasing the barrier. You're improving the skin function. So it makes sense that you would see less skin infections with a drug that's improving the barrier of the skin. And that's what we saw. The FDA has actually allowed the company to come up with this interesting statement in their label. Dupilumab is not an immunosuppressant. Why did they allow them that? Because we didn't see systemic infections. There were no systemic cancers. And so this is not exactly true, right? I mean, think about this statement. I think what they're saying is that it's not like prednisone. It's not like cyclosporin. It's not like Cellcept. But it is suppressing the Th2 arm of our immune system, which actually is involved in parasite control. Parasitic infections are controlled through Th2 cytokines, Th2 T cells. So it's just a highly selective immune suppressant. It's not a general immune suppressant, right? So, but it's interesting they allowed that language, and I think for the reasons we talked about. Now, no blood test monitoring. One thing I didn't show you in the safety slide is anything about laboratories. So it's because we didn't see anything. We didn't see drops in blood counts. We didn't see liver enzyme elevations. We didn't see anything. So there actually no blood test is recommended, no blood test monitoring, including no TB monitoring is needed with this drug. Why? It's Th2 targeted. Th2 cytokines are not involved in TB pathogenesis. So you expect a null effect for TB control. So very different from other biologics we see. So let's talk a little bit more about the conjunctivitis. This is a patient of mine. You can see on the medial aspect of the left eye there is red. This actually is one of the teenagers. Here's a patient that doesn't have conjunctivitis, but has what we call blepharitis, which is inflammation of her eyelids. And so in my experience, and I've seen this a number of times, it's not just conjunctivitis. It's eye issues. We see sometimes dry eye, sometimes eye pruritus, itchy eyes, and no redness, sometimes conjunctivitis, sometimes blepharitis, sometimes all of the above, or just one or the other. So to say conjunctivitis is too simplified. So when you're talking to patients, I would recommend that you actually say, look, I want you to monitor your eyes. I want you to tell me if they're dry, if they're itchy. So that's the main thing you're going to be asking in the follow-up, and both at the start of therapy and in the follow-up. Now, what do we do? So let me just kind of summarize a lot of things here. So it's the most common side effect of dupilumab. We don't know the reason why. The pathogenesis of this is unclear. We're still working on it. There are biopsies being done, conjunctivitis. We still don't know. This is not allergic conjunctivitis that the patients have at baseline. That tends to get better. Right? The itchy, runny eyes that atopic may have, that tends to get better. It's more Th2. This is something else, and we're not really clear exactly what it is.
Have
A
you
range of clinical manifestations.
Have you looked at like the tears, the
It's being
just
done.
for eosinophils or
It's
just
being done by, there's no conclusion as of yet. So
Do you
I would tell you if there was a conclusion.
is there? Well, I mean, what's your hypothesis of what could be happening?
I think there's a whole bunch of different hypotheses. So there's some literature on IL-4 being involved in tear production. So if you're blocking IL-4, you're blocking tear production. I don't want to comment further because there's just not enough information. Most cases tend to be more mild to moderate, although this can lead to them stopping the drug. You can see more severe eye disease in the patients. There's a handful of patients that have had to stop because of this problem. I usually start off with wetting eye drops, and then I usually send to ophthalmology for more further management. I in particular don't like to. Oh shoot! I'm waiting. I'm gonna have to speed up. I'm sorry. I like to refer to ophthalmology. All right. So key points here we've got an efficacious biologic for AD. Asthma, it's indicated now for asthma. I kind of went over all the key points for dupilumab. So this slide summarizes the data on the 2 IL-13 blockers that's known to the public. So we have, on the left, we have a drug called tralokinumab and lebrikizumab on the right. Both of these studies were complicated by the use of topical steroids running in before the treatment. And so they show a dose response, but we really don't know yet the full potential of these IL-13 blockers, and they're both in phase 3. So I personally think that they're working, that we have evidence of them working, so that more is needed, more study is needed on these 2 drugs. This is the NEMO data, that was the New England Journal I mentioned. But here we have the pruritus score. So this is improvement in pruritus due to blockade of IL-31 receptor alpha. All right, so now...
So, just a quick question on the anti-IL-31. I mean, what will that add versus dupilumab?
Good question.
I mean,
So it's a good question because if you look closely at the eczema data, the effect on eczema, in my personal opinion, is not so great. So yeah, we can control itch. So the idea here was if we can control itch in an AD patient, then maybe they would have no skin disease. So the itch, that rashes. So if you target itch, perhaps you won't have the rash. But the data so far suggests that it is good on the itch, but not so great on the eczema. So a friend of mine has said, yeah, they don't itch anymore, but they still have their eczema.
But there are other diseases where you itch and you don't have atopic dermatitis.
That's true. A number of pruritic diseases in dermatology. So now we're talking these days about JAK inhibitors. There are 3 of them that are in the mix, and we have some phase 2 data. They're all in phase 3 for AD. So why JAK? If you remember back at my MOA slide, we have IL-4R alpha, then downstream, intracellularly, is JAK1. JAK1 is the step intracellularly, and so these drugs are oral drugs. They're small molecule inhibitors that are going inside the cell and hitting the same pathway that we see dupilumab working on. So as far as data, it's interesting that the second 2, well, I can only say for the middle one, it's only been real. The data look even better than dupilumab with JAK1 blockade. So we're seeing IgA01s of over 50%. IgA01s of over 50% in the phase 2 data. Okay, so these are pills, but so the caveat here is it's more broad blockade of the immune system. So you're hitting a group of cytokines rather than 1 or 2, more than just IL-4 and IL-13. So that's the caveat here. Are these drugs going to be safe for patients?
You made early on that you want to hit the Achilles heel of the disease. And even with dupilumab, it makes me wonder, well, we have IL-4 and IL-13 for important biologic reasons. So it's interesting that you get away blocking them with no apparent harm.
Or in the eyes, maybe. Yeah. Something we didn't know about. Okay, so I am wrapping it up here. So the status, basically, of the things in the pipeline. We've got dupilumab. We've got 2 selective IL-13 blockers. We've got an IL-31 receptor blocker. Mepolizumab, which you guys know, blocks IL-5. That's been studied in AD. We've got an upstream blocker, IL-33, a number of companies that have anti-IL-33 blockers, and of course JAK1 blockers, which are quote-unquote hot right now, enrolling in phase 3 trials. So this leads us to practice, back to practice. And I'm showing 2 slides here, and we're seeing dupilumab immediately being placed high up in the therapeutic ladder.
for moderate to severe AD. Why? And not step edit. Why? Because the efficacy data and the safety data are better with this drug than they are with cyclosporin, methotrexate, CellCept. And so here you see one group saying there's no step edit, you can go right to Dupilumab, or you can do systemic immunotherapy. And then this is another expert group, a second paper that actually recommends Dupilumab as first-line systemic therapy. And why? Because of efficacy and safety, not because of cost, of course, but because of efficacy and safety. So you see these drugs really coming to the fore in practice. They're supplying a need that we haven't had. We've had much more toxic drugs, less effective drugs, harder to use drugs in the long run prior to this group of drugs that we're talking about now. So thank you for your attention, and hope you learned something.
Does it work for hay fever?
Too expensive for hay fever.
Yeah, but if you take out 3 diseases at once, you take out asthma, you take out get rid of allergy
We'll be
shots.
out of business.
I know, we're gonna get rid
I'm not aware of data. I don't know if there's data on hay fever. You'd expect it to, right?
Yeah.
H2 mediated disease. Yep. All right, I'll be around for a few minutes if you have other questions. Thanks.
Thanks again.
I was just thinking we saw patient Sam when I she's got Oh, here. No, I don't know.
The invitation.
Appreciate you have to be a clinical member. You're starting clinic, so there'll be an icon.
Just another question.
That won't be until January.
There's a clinic now?
There will be the first couple of floors of the new building on Riverside. It's going to be diabetes and and then when the temple opens up,
No, I know.
It's all coming out of the cover. How fast the yeah, it's a good question. Ask Francis to
I mean, I'm doing it. No, I'm just wondering what all the is so pretty. Isn't it?
You mean on the inside?
I get
We have Francis
It's like that. Yes. Yeah. Oh my God.
so funny. She comes to bed.
And she can her hair
How was your treatment?
Yeah, so they like less.
Right after.
The whole afternoon.